Audiology and hearing loss. Audiology and hearing loss, hidden threshold, types of hearing loss, diagnostic techniques, audiometry, tympanometry, otoscopy, UAE, ABR, functional consequences, threshold, loudness, masking, etc. Auditory system. We have outer, middle, and inner ear. Outer ear belongs to the acoustical system with the pinna and ear channel and eardrums, and the middle ear contains the ossicles, and the inner ear, middle ear and the inner ear, the cochlea, and also some balance semicircular canals, important for the balance. And it's a mechanical system. From the sound from the outer ear is transformed to mechanical oscillations in the cochlea by the ossicles. And then there's last but not least, the auditory nerves. The neurons in the auditory system will bring some electric impulses from the oscillation from the basilar membrane via some hair cells, and so it goes to the brain, those signals, and we can hear the sounds. Okay, we have some playing A, B, C, D, E, F, G, some different music, for instance, or voices, and there's a bass response to high frequency, about up to 20,000 hertz, and apex is less for instance, the tone A, it's in the apex response to low frequencies. We have this organ of Corti with the textural membrane and the hair cells, inner hair cells and outer hair cells, and and the outer hair cells bring the textural membrane to oscillate or move and enhance the basilar membranes or vibrations. Okay, and so the inner hair cells, from the inner hair cells goes to a kind of rectifier, a low pass filter, and it brings it converts the oscillations to electric signals or potentials in the neurons. Hearing loss. What are common pathologies? How can we diagnose them? What are the functional consequences of hearing loss? We have the outer ear, common outer ear pathologies is deforming of pinna, collapsed channel due to external pressure, blockage, build up of airwalks is called the axa cerumen, and typical membrane eardrum, trauma, perforated tympanic membrane. I have some experience by that. The middle ear, common pathologies, so-called otitis media, inflammation of the middle ear, leads to fluid in the middle ear, reduced transmission of sound to cochlea. Very common in children. Otosclerosis, abnormal bone growth inside the ear. Surgery possible. Also often hearing aids needed. Desarticulation or fixation of ossicles. The inner ear, Okay, we have the cochlea with the membrane, and this organ of Corti with the, as I talked about before, with the basilar membrane between the. We have some scala vestibula with liquids, scala media and scala tympani, and between scala media and scala tympani there is a basilar membrane. Okay, The cochlear hearing loss because of inner hair cells, outer hair cells, normal system. The hair are great, but after damage can be exposure of noise or age. Those hair cells are damaged. Loss of outer and or inner hair cells, noise exposure, age, genetics, orthotics, chemicals, and so on. Okay, what is the function of inner hair cells? There's those stereocilias. They are moving to right and middle and back. When they're moving to the right, the inner hair cells keep some neurotransmitter, and they're connected to auditory nerve filter. When the stereocilia bands to the right, this neurotransmitter are moving, and the hair cells are depolarized because of some liquid movements, and then the neurotransmitter is released, and it brings activity in nerve fibers in form of so-called spikes. Stereocilia bent to the right. There's a depolarization about -45 millivolt. Stereocilia bends to the right. Tip links open ion channels, yes, and potassium ions enter cell, depolarization of cell, release of neurotransmitter, spikes generated in a neuroauditory system. Transducer from mechanical to electric signal is about this inner hair cells. Metabolic activity is required to maintain iron concentrations. Metabolic loss means reduced iron concentrations gradient. Reduced means reduced voltage, and that means impairs transduction. Okay, metabolic loss. Okay, didn't know. Then we have some deafferentiation. We have some afferent and efferent neurofibers. Afferent is from the hair cells up to the brain, and the efferent is the other way. Deafferentiation. That means elimination or reduction in sensory neurons. There are some, okay, and then there are big story about neural activity along escanding auditory pathways. What could happen? Loss of neurons and tumors also. Yes. Okay, and this hair cells. There's a so-called synapse between the hair cells and the auditory nerve fiber. Demyelinating. That means that the package of nerve cells are decreased. This myelinating, I mean, it's kind of fat, and it's for normal cells. It's very important. Okay, damaged nerve in MS means that the influence in passage of nerve impulse. There's some disturbing. Yeah. Action potential conduction speed. Unmyelinated is the conduction speed is up to 10 meter per second. Myelinated 150 meters per second. Overview: causes of hearing loss. Genetic cause, very complex genetics, from birth or late onset. Congenital, from birth, often unknown underlying cause, sometimes due to medicine during pregnancy, oxygen deprivation at birth, premature, and so on. And then acquired or related to outer or middle ear. Cerumen, outer or middle ear. Cerumen blockage, airbox. Mechanical trauma, often middle ear. Eardrum perforation, I know that middle ear infections, otitis media, Eustachian tube issues, otosclerosis, often surgery or other medical treatments possible. Acquired or related to inner ear or higher auditory pathways. Age-related, noise-induced oxytoxicity, medicine, sudden deafness, Meniere's disease, tumor, often no medical treatment, for instance with age, noise, which are most common hearing devices needed. How do we diagnose hearing loss? Behavior tests, sometimes called subjective, or electroneurophysiological tests, sometimes called objective. The outer ear. How can we diagnose problems with outer ear? Diagnosing outer ear pathologies. Otoscopy. Visual inspection of the outer ear and tympanic membrane. Blockage of seaming, inflammation, scarring, perforation, retraction, obvious abnormalities. And the middle ear, how can we diagnose problems with middle ear? So-called tympanometry. There's something about what's called earplug in the ear channel and some microphones and loudspeaker and so on. And so we can measure the intensity and the compliance and so on, all this stuff. So-called tympanometry. Yeah. Yes. High and low pressure and so on. The inner ear. How can we diagnose problems with inner ear and higher on the auditory pathways? You have the inner ear that belongs to the cochlea and the semicircular canals. Hearing threshold requires response from listener. Diagnostic test should be accurate, fast, standardized. Accurate, fast, and standardized. Again, we have some from field to audiogram. If you have a normal hearing loss, hearing threshold curve, where it's in minimum about 3,500 hertz, and it's increasing for higher frequencies and lower frequencies. Yes. If you translate it, can you say to audiogram, normal listening is 0 dB hearing less. But for elder people, the hearing loss will increase with the frequencies. Yeah. How do we measure it? How do we produce a sound? What procedure do we follow? You start well above expected threshold. If yes, then decrease level by a large step, for instance 10 dB. If no, then increase by a smaller step, for instance 5 dB. Stop treat as counting responses at same level. This should be the so-called as counting method. The audiogram. The audiogram, we have some normal thresholds. Example of typical audiogram from an older adult with age-related hearing loss. So about when you are 80 years old, when you're hearing nothing about the age. Left ear and right ear. Left ear is a cross and right ear is a circle. So there's a hearing loss about 70 decibel at 8 kilohertz. Can diagnose different types of hearing loss from pattern of the audiogram. Audiogram is still gold standard. Pure tone audiometry is most common in hearing test. That was part 1.